2017, there you were. You were perusing the New England Journal of Medicine like you are wont to do, and you came across a paper by Dr. Kudenchek. This was the ALPS trial, and you really remember this one. This one stuck in your brain because, like me, you really weren't sure what to make of this study. So this was the study. It was a ROC paper, 10 sites, great big trial, very well done. They compared adults with out-of-hospital cardiac arrest and VFib or VTAC refractory to 3 shocks, and they randomized them to amiodarone, lidocaine, or placebo, ALP. So that's the ALPS. And they wanted to see what the difference was in survival to hospital discharge and neurologically intact survival. And the reason you probably remember this study, the same reason I remember this study, is they found no difference. No difference in amiodarone compared to lidocaine, no difference in amiodarone compared to placebo, and no difference in lidocaine compared to placebo. Blew my mind. Still think about that paper. Well, with that in mind, I read with great interest a new paper by our buddy Tanner Smida. So he used the ESO data set, several years worth, and he said, I want to replicate that trial, the ALPS trial, with something called target trial emulation. Now, if you're also like me and you're like, what in the hell is target trial emulation? Then boy, do I have a podcast for you, because I reached out to Tanner, and being the incredibly generous person that he is, he said, of course, Jeff, I'd be more than happy to talk to you about our work. So stick around because I want to share this wonderful interview with you. But before I do that, I think all of us need to congratulate Tanner because he just got married. So congratulations, Tanner. I'm so happy for you, man. Really, really excited about your career, and I am so happy to see you so happy. All right, guys, stick around. We'll be right back with the interview with Tanner.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Tanner Smida, you know, I talk about you on this podcast all the time, usually complaining about how smart you are. Welcome back to the podcast.
Thanks for having me.
So what we're going to talk about now is a really cool paper that you just did using some funky analysis that I want to talk to you about, but it is fundamentally about comparing the effectiveness of lidocaine versus amiodarone in patients with out-of-hospital cardiac arrest, particularly shockable rhythms. In order to help us understand this, would you mind just giving us a quick background on what the information was, where the science was leading up to your paper, so we can put the results of your paper in some context?
Yeah, absolutely. So there have been a number of observational comparisons of these two drugs, but more importantly, there have been a couple randomized clinical trials, right? Kind of the top of that pyramid of evidence. And so kind of to start out, there were a few single center, smaller studies. And then they were followed in 2018 by the ALPS study, which stands for amiodarone versus lidocaine versus placebo. It was a large resuscitation outcomes consortium trial that enrolled about 3,000 patients with shock refractory VF or VT, which was defined as one or more defibrillations, followed by failure to terminate those rhythms and achieve ROSC. And so patients were randomized in this placebo-controlled double-blind study to either receive lidocaine, amiodarone, or essentially a saline placebo, right, a control medication. Then investigators followed these patients forward and examined outcomes, including patient-important outcomes like discharge with a favorable neurologic outcome and survival to hospital discharge. And essentially the bottom line of this rigorous, high-quality randomized controlled trial was that in comparison to placebo, neither lidocaine nor amiodarone is able to move the needle on favorable functional outcomes or neurologically intact survival. Now, there were some kind of subgroup analyses of this large clinical trial that suggested that antiarrhythmics might benefit some patients within predefined subgroups, like looking at EMS witness arrest. There were some secondary analyses looking at IV versus IO administration of medications, and there's some suggestion that there's some heterogeneity of effect based on the route of medication administration. But again, the bottom line of the evidence that existed before we did this observational study was that with respect to patient-oriented outcomes, there was no difference between these two antiarrhythmic agents, and in fact, no difference between these two agents and saline. So.
I remember when that came out thinking, well, crap. Now what? So I was definitely surprised by that. And if I remember correctly, speaking of things that surprised me, that analysis, that trial was done concurrently with the continuous CPR versus interrupted CPR. Also, results from which led me to say, oh crap, why isn't there a difference? At least with that one, we've had some additional evidence that maybe is giving us more of an answer. Maybe with this topic also, we're getting some additional evidence to help us understand it a little bit better. Tell us what you did to look at this same question, but maybe with a different data set.
Sure. Yeah. So in order to compare these two antiarrhythmic medications, we went to our favorite pre-hospital data set, the ESO Data Collaborative. And
wonderful opportunity.
Right. For those of you that don't know, ESO is essentially a software vendor for EMS agencies all across the United States. They provide electronic health record software. And importantly, so participating agencies, all of the data that they put in to their electronic health records, demographic data, treatment data associated with the timing of interventions, and outcome data as well, all of that data on an annual basis is de-identified and then included in these annual data sets that are provided for free to researchers across the country, right? So they can answer questions like this one. And so we looked at patients who were treated between 2018 and 2023 in these annual data sets. And we looked specifically at out-of-hospital cardiac arrest patients who experienced a cardiac arrest prior to EMS arrival, who presented to EMS with an initially shockable rhythm, so either ventricular fibrillation or ventricular tachycardia. Of that patient population, we then, we applied some further exclusion criteria. So we excluded patients who were less than 18 or greater than 80 years of age. We also excluded patients who were residents in a nursing home or assisted living facility at the time of their cardiac arrest. And then, some other standard exclusion criteria, patients who had resuscitation limiting advanced directives were excluded, as well as patients who had essentially post-ROSC antiarrhythmics administered, right? And then, of course, anybody who didn't get amiodarone or lidocaine in the pre-hospital setting, they were not included.
That would be kind of hard to study the effect of amiodarone or lidocaine if they were
right, exactly.
Yeah.
Yeah. So these
now, you excluded EMS witness arrest, right?
That is correct. Yeah. So these cardiac arrests, they all occurred prior to EMS arrival.
Perfect. We can do that because I think that's really interesting that you did that.
Sure. Yeah. And then we basically sorted patients into groups based on whether they got amiodarone or lidocaine as their first antiarrhythmic in the pre-hospital setting if they received more than one antiarrhythmic. Then we compared the outcomes of these two groups using a statistical method called propensity score matching. And so propensity score matching, it's essentially a method where, there are a lot of factors that influence the outcomes of cardiac arrest patients. And there are also factors that may influence what treatments cardiac arrest patients receive. With propensity score matching, you essentially generate a propensity score using a regression model usually. And that score contains information about the probability that a patient is going to receive a given treatment. And so to generate this propensity score, we used a bunch of different relevant variables. So age, sex, witness status, whether bystander CPR was performed, the response interval, how long it took from on-scene time to actually administer the antiarrhythmic medications to the patient. And then we matched patients based on these propensity scores. And so essentially what you get is when you take, patients who got amiodarone and patients who got lidocaine, and then you match those patients with regard to those propensity scores, you end up with two very similar populations of patients with respect to their probability of receiving whatever antiarrhythmic agent we chose as our reference group. So this essentially allows us to control for confounding variables that influence both cardiac arrest outcomes and influences the probability of receiving a given treatment. And so once we performed that statistical analysis, we looked at a few outcomes. So our primary outcome was pre-hospital return of spontaneous circulation, so getting a pulse back in the field, regardless of duration. That's how we defined it, as well as a number of secondary outcomes. So the first secondary outcome we looked at was survival to hospital discharge. So about 1 in 5 patients in the ESO data sets have hospital disposition data. So we can tell, did they go home? Did they die? Did they go to hospice, rehab facility, et cetera? So we derived survival to hospital discharge data from that subgroup. We also looked at the number of post-drug defibrillations that patients required. And then among patients who achieved ROSC, we also looked at whether patients had post-ROSC hypotension, post-ROSC bradycardia, or required post-ROSC transcutaneous pacing. We looked at those outcomes because there's some suggestion from the ALPS trial and from some other literature that suggests that amiodarone may contribute to post-resuscitation hemodynamic instability, and amiodarone administration may increase the probability of requiring pre-hospital transcutaneous pacing. So that was kind of some safety signals that we looked at.
And I would say common use of amiodarone in non-arrest patients will probably give you that impression also.
Right, exactly, yeah. Yeah. And so in terms of our outcomes, so we found that essentially for all of these outcomes that we looked at, lidocaine was the winner. So lidocaine use was associated with increased probability of ROSC, increased probability of survival to hospital discharge. Patients who received lidocaine required fewer post-drug defibrillations prior to return of spontaneous circulation. And then among the patients who achieved return of spontaneous circulation, patients who received lidocaine were more stable. So those patients who got ROSC and also got amiodarone, they were more likely to be hypotensive, bradycardic, and require transcutaneous pacing post-ROSC.
So that's the direction. Overall, we're seeing improved survival, or at least improved ROSC, definitely, with lidocaine, perhaps some improved survival. Can you go over what the actual numbers were?
Yeah, absolutely. So the patients who received lidocaine, 36% of those patients had pre-hospital return of spontaneous circulation, in comparison to only 30.4% of the patients who got amiodarone. So the absolute difference is 5.6% there. So in terms of an odds ratio, that's an odds ratio of 1.29. The confidence interval goes from 1.16 to 1.44. So it suggests that if you got lidocaine, your odds of pre-hospital ROSC were between 16 and 44% higher than if you got amiodarone. And then in terms of our secondary outcomes, so survival to hospital discharge, once again, patients who received lidocaine, 35.1% of those patients survived to hospital discharge, compared to only 25.7% of patients who had amiodarone administered. That's an absolute difference of 9.4%. The odds ratio there is 1.54, ranging from 1.19 to 2, so between 19 and 100% higher odds for spontaneous survival to hospital discharge if you received lidocaine.
Very good. You also looked at a couple of other post-ROSC adverse events, so hypotension, bradycardia, and I think you did need for transcutaneous pacing. Do you mind going over those results also? Because I thought they were also interesting.
Absolutely, yeah. So patients who had lidocaine administered and then achieved return of spontaneous circulation, those patients it was an odds ratio of 0.8, so about a 20% decrease in their probability of experiencing post-ROSC bradycardia. The odds ratio for post-ROSC hypotension was 0.77, ranging from 0.61 to 0.96. And they were also less likely to receive pre-hospital transcutaneous pacing. So their odds there were about 50% less. So odds ratio of 0.50, ranging from 0.34 to 0.72.
That's interesting. And I know we shouldn't read too much into this, but it looks like the effect size, just an absolute effect for ROSC, is less than it is for survival to discharge. It seems like the impact grows the further on you are. And like I said, we shouldn't read too much into that, but it is interesting. Usually see it the opposite way.
Yeah, and it suggests that either perhaps there is some bias that creeps in here with respect to our survival outcome. So the reason we picked ROSC as our primary outcome as opposed to these survival outcomes is because of an inherent limitation of the ESO data set, where only 20% of transported patients have outcome data. And here we're studying an intervention that can influence the probability of transport, right? If you have ROSC, you're more likely to transport a patient to an emergency department. And so there's potentially some collider bias or other bias that's at play here in influencing our estimate of effect size with respect to our survival outcomes.
Good point. Just your bottom line number of patients that you could use in the analysis for ROSC is way bigger than the number you could use for survival to discharge.
Yeah, that's true. So also, I mean, I guess in general, we're just going to get wider confidence intervals. So we can have, a really high effect size or a really low effect size just because of that range.
Makes sense. So speaking of survival to discharge, and can you tell us a little bit, this is a methodology that you came up with, and I don't know if you know this, but a lot of folks are stealing that methodology when doing analyses with the data set. So thank you for doing that. Can you tell us a little bit about what you looked at to figure out survival to discharge? You're essentially trying to approximate meaningful survival here, right?
Sure. Yeah. So we've done this in past papers in a slightly different way. So we get all this from disposition data from the hospitals. So when a patient is discharged, they get a disposition entered into their chart that's captured by that bidirectional health data exchange that ESO participates in. And so, we'll essentially, for just looking at survival to hospital discharge, we'll classify all the patients who were discharged to home, a nursing facility, rehab. We'll classify those patients as surviving. And then we'll classify all of the patients who died prior to hospital discharge, right? So they had a discharge disposition to the morgue or organ donation or just listed as deceased, as well as patients who were discharged to inpatient hospice. We classify all of those patients as deceased. Previously, we've also looked at survival to discharge to home as a proxy for good neurologic outcome. And so, again, we're just kind of classifying patients differently. Everyone who's discharged to home is in the numerator, and everyone else is in the denominator, including those patients with perhaps a poor functional outcome who go to a rehab facility or a nursing home.
Perfect. And I think that is probably a reasonable approximation when you look at some of the RCTs that are reporting both survival to discharge and functional neurologic with an MRS or a CPC. Those seem to predict each other fairly well. So I think that's probably pretty reasonable. Well, let's go back and talk about your exclusion criteria here, because I really like what you did. If I read correctly, you excluded patients that were over 80. And when I read that, I'm like, oh, I think I know why. And then you also excluded EMS witnessed arrest, and I had no idea why you did that. And all I needed to do is keep reading. You explained it, and I realized that I was completely wrong on the reason you excluded the 80-year-olds. I was going for the once you're above a certain age, you sort of become identifiable. But it looks like that wasn't your rationale for excluding them. Can you talk us through why you excluded both of those groups?
Yeah, absolutely. So, and this also comes, I know we're going to talk about target trial emulation maybe later, but one kind of important thing about that method is that it forces you, when you're designing an observational study, to sit down and think about how you would answer the question if you were asked to conduct an ideal randomized clinical trial, right? And so in all of critical care medicine and emergency medicine, with at least with respect to trials, an eternal problem that is faced, and a problem that results in many null trials being published, is that you really have three groups of patients you have to contend with. You have one group of patients that are pretty healthy, and no matter what you do for them, they're probably going to be okay, right? A little bit of supportive care, they'll be fine, right? And so those patients, they're not going to contribute to our understanding of whether an intervention can benefit or harm patients, because no matter what you do, they're going to be okay. On the flip side of the coin, you have patients who are so gravely ill, they're so sick, that no matter what intervention you provide, we're not going to save them, right? The 90-year-old person in a nursing home with end-stage dementia, unwitnessed asystole, right? You could give them amiodarone, you can give them lidocaine, you can put their head up, you can stand them on their head, right? Whatever you do, they're not coming back, right? And then in the middle, you have a group of patients that are kind of in a gray zone, right? Where our interventions may actually have an influence on these patients' outcomes, right? They're on kind of a knife's edge, and our interventions can push them one way or the other. And those are the patients you want to enroll in clinical trials, right? The rest of it's kind of noise that can obscure effect size. And when it comes to a clinical trial, it's really expensive to enroll patients, right? Sometimes over thousands of dollars per patient. If I was running a cardiac arrest trial, I wouldn't want to enroll the 90-year-old nursing home patient, right? And so while sitting down and thinking about that, we said, okay, we don't want anyone over 80, and we don't want patients in nursing homes or rehab facilities at the time of their arrest, because there's a high degree of comorbidity, perhaps poor baseline functional status, right? That can kind of obscure the effect size that we're looking for. These are not the people whose hearts are too good to die, right? That we talk about. And so we did that to kind of enhance the homogeneity of our cohort. And then on the flip side, right, same thing with the EMS witness arrests. Slightly different patient population, right? They're getting a bunch of interventions dropped on their heads at once. They're more likely to respond immediately to defibrillation. They probably already have vascular access established in a lot of these cases. And so that's our rationale.
I love that, because the flip side of the problem you were trying to solve, this heterogeneity, the widely different patients, we were talking about it here in terms of a research study, but I think it has a huge impact on the fact that we cannot stop beating ourselves about the lack of progress in survival to cardiac arrest. We always do, especially things in the media, but we do it to ourselves. We talk about, survival from out of hospital cardiac arrest was like 8-9% 30 years ago, and it's 8 or 9% right now. My God, we suck. Why do we suck so bad? Why aren't we better? Why haven't we fixed ourselves? And I think this is a large part of it. The majority of our patients are elderly and aren't going to survive no matter what we do. Maybe we should focus our efforts on not resuscitating them and not, torturing them, and then focus our efforts on the patients who are likely to benefit. So I love that. The other thing, by the way, that we're really good at doing is comparing apples and oranges. When we say Seattle is wonderful, they have 60% survival. We suck because we're at 10% survival. And we are vastly comparing different groups. There's an Utstein survival, and 60% Utstein, still very good. Not trying to say anything bad about that. But to 8%, if your Utstein survival is 8%, yeah, there's a big problem there. But just mixing and matching is really a challenge. So I'm glad you did that. It's an interesting concept, and as I'm thinking about this, I'm not aware of any of the large ROC trials or any prior cardiac arrest studies really that did that tried to reduce that variation. Are you aware of any?
So I know, at least in a couple like more recent trials that I've been reading, that they've been excluding unwitnessed asystole in some of these patients with an extremely grim prognosis to kind of it has the same intended effect,
Yeah.
is to increase the homogeneity of our study populations. But maybe we should go back and do some subgroup analyses and look only at these age
Yeah.
ranges, excluding unwitnessed asystole, to try to remove some of that noise from this trial.
I would love to see that, particularly in paramedic too. I mean, that affects essentially every arrest that we run. So yeah, that would be fascinating. So we're in a little bit about some nerdy stuff here. So I want to follow up on the methods question and ask you about this target trial emulation. We've talked about propensity matching here and regression here all the time. Rimley's come on and given us all the details about it. I don't think we've ever talked about target trial emulation here. So I could be wrong on that, but I don't think so. So at least I need a refresher. What the hell is that?
Sure. Yeah. So essentially, target trial emulation describes a published method that allows you, when you're approaching an observational data set, to avoid many common sources of bias that plague observational research, right? So it's essentially a checklist, right? And if you have a question that is amenable to emulation, and you have a data set with enough granularity to perform emulation, then using this published set of methods with an observational data set, the argument is that you can get pretty close to the effect size that you would get from a randomized controlled trial should it be conducted, right? And that seems like a pretty crazy claim. I admit it. I think it sounds pretty crazy, but there have been validations of this method tested. So basically, a group of investigators got together and they took, like 30 trials that have been published previously in the field of cardiology, so looking at beta blockers, different anticoagulation strategies, and then they attempted to use this method to emulate those trials using observational data sets, so like Medicare and Medicaid data and big payer claims databases. And what they found was that, once again, if you have the data available in a data set, you have a question that's amenable to emulation, you end up with observational data getting effect sizes that are very similar to the effect sizes that are produced by randomized clinical trials. I mean, I can send a link to that paper or that series of papers for you to put in the show note if your
Yeah,
listeners are interested.
I'd love to. I would say maybe 1% of our viewers are, all of our guys are nerds. Otherwise, I mean, seriously, why are they watching this? That's an extra bonus points for nerdery. But I definitely want to see it just so I can live up to the nerd label here. You mentioned target trial emulation is a checklist. So it's like a better living guide to doing observational studies. Is that right?
I think that's a good way
So
of characterizing it. Yeah.
there is, from what I've heard you tell me in the past, it seems like there is one thing in here that's really different other than just that we might not do in an otherwise really good observational study. So I like to think some of the observational studies I've done have certainly followed the strobe guidelines, but you keep talking about really making sure you're defining the time to intervention and your zero time. So can you tell me a little bit about what that is and why it's so important?
Yeah. So essentially, in a randomized clinical trial, right, a couple things happen at time zero. So first, your patient is eligible at time zero. They also receive the intervention at time zero, and then follow-up begins for outcomes of interest at time zero, right? So time zero would be like in the ALPS trial, when they open the drug box and they give the syringe of drug, that's time zero, right? The problem is in observational studies, time zero is often misaligned between groups, right? And so that leads to a phenomenon called immortal time bias. I believe you've talked about it previously on this podcast in the context of resuscitation time bias.
Yeah.
So, for example, if we're studying bicarb or calcium, right, these drugs are typically given late in resuscitation. And so the patients who get ROSC early, right, and don't have an opportunity to have bicarb given are automatically in the no bicarb group, which makes bicarb look artificially harmful. And there's 1,000 studies out there that say that bicarb's harmful. And a lot of
Right.
that is likely resuscitation time bias. So making sure that time zero, that you can define it, and making sure that it's aligned between the two arms of your study is a very important part of this method.
So how I want to dive in a little bit because that concept I understand. Um, Help me with it. In this trial, how did you, or in this study, how did you make sure that time zero was time zero in both arms?
Sure. Yeah. So we got and honestly, the reason that we did this study in the first place is because ALPS had been previously published, right? And so we were essentially just trying to go and redo ALPS to see if we would get a similar estimate of effect size, right?
Okay.
I didn't go at this and say, I'm not a believer in amiodarone. I believe that lidocaine's better. I was sold by, on first read, my read of ALPS was that amiodarone seemed to be like maybe it was the better medication, right? So the ALPS has a couple advantages. So right, first of all, it's already been done and published, and it was actually a randomized controlled trial, not based on observational data. Another huge advantage is that for the two treatment arms, it's two active treatments, right? That's really, really important. It's very difficult. I'm not going to say impossible, but it's difficult to do observational research comparing something to nothing or something to a placebo for two reasons. One is the misalignment of those times, right? Resuscitation time bias comes into play. Also, confounding by indication, right? Patients that get an intervention are typically very different from patients who do not, right? If you went into ESO and you said, okay, I want to do a study to see what influence epinephrine has on the outcomes of patients with allergic reactions, and you looked at everybody with the primary impression of allergic reaction, and then you look at the patients with epi and the patients who didn't get epi, you're going to see a bunch more death and morbidity in the group of patients who got epi because they were sicker, right? And that's why they got the
Right.
epi in the first place, right?
Right.
So by having our two intervention arms both having active treatments with identical indications, right? These are both medications that are recommended for shock refractory VFVT. They're going to be administered at similar time points in the resuscitation. The thing that governs their administration is primarily, does your agency stock it? What does your agency's protocol say to give first? And then, perhaps maybe there's some individual provider preference where I've always given lidocaine, so I'm going to keep giving it, that sort of thing, right? And so because both of these drugs are indicated at essentially the same time point in resuscitation, once you get vascular access and identify shock refractory VF, matching those patients based on time to drug aligns those two groups at time zero. So it's part of it is also you have to try to pick the right question, right? And so,
Yeah,
an
you
example
mentioned if a study question was amenable to it. So what types
right.
of things would be amenable to it versus not?
Yeah, so I would say personally, to do what we did, to use the methodology that we used, ideally you would have two active treatments that are indicated for a disease process at a similar time point during that patient's care, during resuscitation or whatever other disease process that you're studying. So yeah, and that's a comment that they've made in the literature validating target trial emulation is when you try to emulate placebo-controlled trials, your estimates of effect size are not as close, right?
Yeah.
Which I think is predictable knowing what we know about these sources of bias that we've been discussing.
Perfect. Lest we make this a 3-hour podcast, I think that's probably about enough on the methodology. So your results showed, I think I remember 24 to 30, somewhere in there, % increased odds of ROSC and roughly similar increase in the odds of survival with lidocaine compared to amiodarone. Compare that, if you will, to what you told us at the beginning of the podcast about what we knew coming into your trial. I've been on this kick about Bayesian analysis recently, where you take new information and apply it to what you already knew. Let's just conceptually do that here. How do you put your results in the context of ALPS?
Yeah, so in terms of survival to hospital discharge, there's certainly a stark disparity, right? ALPS really suggested that there was no difference between these groups. However, there is congruence with ALPS for our primary outcome. So looking at return of spontaneous circulation, the ALPS trial actually did suggest that patients who received lidocaine, in comparison to patients who received amiodarone, they had a higher probability of ROSC at emergency department arrival. Now, in the main paper, they report the per protocol analysis. And so from a frequentist perspective, it did not reach statistical significance. It was like a p-value of 0.07. There was a 4% difference in favor of lidocaine, which is pretty similar to the 5.6% difference that we identified in our study. So maybe there's something to it, right?
Yeah.
But if you dig into the supplement and you look at the intention to treat, right, so kind of the as randomized analysis, it actually does reach statistical significance. So from a frequentist perspective, it goes
Right.
0.03. It hits that magical threshold. So
and even if you just look at the numbers, so just an absolute difference, amiodarone versus lidocaine, because I wrote this down, I'll go over it. For admission, it's fairly close. It's showing about a 1.3% advantage in ROSC compared to what you show was 4% versus I think you had 5-ish%. And it was really close to significance, even if you're looking at the confidence interval. It was negative, if I can read my writing without my glasses, negative 8.3% absolute difference up to 0.3. 0.3, are you kidding me? That close.
Right.
So yeah, it does seem like maybe you're just identifying something that was fairly close in the original trial.
Yeah, and quite frankly, so whenever once we got the result that we did, and we were like, okay, now we have to go and write the discussion for this paper about how we're going to contextualize this. And I really went back through ALPS with a fine-tooth comb. I was like, wait a minute, we actually got pretty close here for our primary outcome, So from a Bayesian perspective, I don't think it shifts our priors on, does lidocaine improve the probability of return of spontaneous circulation at emergency department arrival or pre-hospital return of spontaneous circulation? Seems like both are pointing in the same direction, right? Our priors from ALPS barely need updated, with this data.
Yeah, I like it.
In terms of survival, again, there's a lot of confounders with survival, including kind of the missingness and the stuff we discussed before. So I don't really know what to make of that. Obviously, their data is much higher quality than, I can say target trial emulation as much as I want. It's still observational data. It's still data that was not collected for research purposes, right? There's a ton of limitations inherent to it, whatever we call it, so.
Yeah. So you've done a very good job as a scientist, really stressing the limitations of that. And I agree with you completely. Who knows? I was really struck with ALPS when it came out about, well, crap, now what? Not to mention just this overwhelming sense of nihilism that, screw it, nothing works. It's frustrating, and a lot of people have been throwing their hands up about RCTs. And I believe the quote was, the age of RCT, and I'm not going to say who said this, but the age of RCTs is over, they're pointless, we'll never find a difference. We need to lean into things like propensity matching analysis and other things. I think it is important to not get too nihilistic about RCTs. I think the real answer here is, turns out research is hard. That doesn't mean we shouldn't try. To paraphrase Kennedy at Rice University, you know what? Going to the moon's hard. We do shit because it's hard, and there's some benefits to it. Now, one of the other things, and I'm going to ask you this primarily because it leads to a really cool visualization that you did. You looked at this data in a lot of different ways. Can you tell us how you looked at it and if it changed your primary analysis at all?
Sure. Yeah. Yes. And so one of the benefits of working with large data sets like this and examining the outcomes of thousands and thousands of patients is you can do some pretty granular subgroup analyses. So we basically looked at our primary outcome of pre-hospital ROSC and our secondary outcome of survival to hospital discharge in a bunch of different subgroups comprised of age. So we split patients were you less than 65 or greater than or equal to 65 years of age. We split patients by witness status, whether you had a presenting rhythm or a VFib or VTAC. How you got the drug, was it through an IV or an IO? Drug timing, what the dosing of these medications, as well as in a subgroup of, we call them Utstein positive patients, so those patients who had a shockable rhythm, witnessed arrest, and bystander CPR. Long story short, across pretty much all of these groups, the signal was consistent and favored lidocaine overall.
I love me a good forest plot. And as reviewer number 2 from my last paper pointed out, if it's not a bunch of RCTs, it's not actually a forest plot, but screw them. I love it. I'm going to keep calling it a forest plot. I love the concept because you really get a good concept here. All right. So what you found with this methodology is an advantage with lidocaine compared to amiodarone, and putting it in the context of ALPS. It's actually not that surprising. We're probably seeing the same thing, just and maybe it's a little clearer here, but the signal was certainly there with ALPS. I like it. So tell me a little bit, if you will, of, let's say I'm going to give you $50 million to create an additional research network. You have 10 centers all in, great ability to do research. You're going to repeat your study in a randomized fashion. What would you do differently, knowing what you know now, compared to what Dr. Kudenchek and colleagues did in ALPS?
Yeah, so there's one thing about ALPS that also came to light while we were writing the discussion, doing some research for this paper, and that's that the version of amiodarone that they used in ALPS is not the version that is available today. And so because they were worried about, perhaps rightly so, about the hemodynamic effects of amiodarone, the hypotension and bradycardia that's been associated with this drug, the drug that the formulations they used in the trial, they removed polysorbate 80 from the diluent, which is the kind of component of the drug that's responsible for a lot of these hemodynamic effects. And so the comparison that they did in that trial is not actually a true comparison of the drugs that are out there on the streets today. And so that's probably something that I do a little different. I do, the generic commercially available medication versus generic commercially available medication. I think that would aid in pragmatic decision making. And although, we can't really definitively point to the fact that there's any aspect of their design they kind of diluted any effect that could be observed between the groups, but certainly I would try to exclude patients who, were again residents in nursing homes or assisted living facilities, greater than 80 years of age, perhaps, again, maybe in collaboration with the consortium that we're creating.
So one other thing that I want to ask you about, you did something that I wouldn't have thought to do, and then you got results that I'm having a hard time understanding what to do with. So you actually looked at agencies where, I believe it was 80%, where the majority of patients were treated with lidocaine, versus agencies where the majority were treated with amiodarone. And that suggests that there is something different about those agencies that use predominantly lidocaine versus predominantly amiodarone. Can you tell us a little bit about that analysis, and in particular what you found? Because that was the thing that was making me scratch my head.
Sure. Yeah. So we were concerned that, like you said, agency differences in resuscitation quality might contribute to some of this difference, right? So one of the agencies that I work for, it's very, very rural community. And until, I think up till this year, they only carried lidocaine because amiodarone was much more expensive. And so we were worried that perhaps, agencies that are less financially well off, these more rural agencies, right, that really have, the cards stacked against them in terms of cardiac arrest outcomes, that differences in practice patterns can influence these outcomes at the agency level. And so essentially what we did is for each EMS agency that contributed patients to our analysis, we went to each of them and said, okay, did you administer more than 80% amiodarone or more than 80% lidocaine during the study period. And then we classified them as either amiodarone predominant or lidocaine predominant EMS agencies. And we identified it was like 160 agencies that gave mostly lidocaine and like 1,300 agencies that gave mostly amiodarone. Then we asked the question, just being treated by one of these agencies, regardless of whether or not you received amiodarone or lidocaine, does that predict outcomes, right? So we asked the question among patients with non-shockable cardiac arrests and among patients with shockable cardiac arrests who did not receive antiarrhythmics, right? So maybe the people who get ROSC early or maybe just never receive antiarrhythmics for whatever reason.
Let me stop you real
Sure.
quick just to clarify. You said you're comparing amiodarone and lidocaine in patients who didn't have a shockable rhythm, which is going to strike some people as odd.
Yeah. What we're really comparing is whether you were treated by an amiodarone predominant agency or a lidocaine predominant agency, right? So in these analyses, none of the patients received antiarrhythmics, right? We're just saying, were you treated by an agency that when they're faced with a shockable arrest that's refractory to efforts,
Got
they
it.
administer amiodarone or lidocaine, right? So
Perfect.
it's, agency practice pattern is kind of the exposure that we're looking at here, yeah.
So the idea here is even in all comers, shockable, non-shockable,
Yep.
Is there something about this? Are the amiodarone agencies better performing than the lidocaine or vice versa?
Exactly, yeah.
Got it. Makes sense.
But essentially what we found was if you were an agency that administers primarily lidocaine, overall, your patients have worse outcomes, right? And so this suggests that the benefits that we're seeing from lidocaine aren't because lidocaine agencies are just really high performers, right? Like one thing we thought about is like, okay, what if Seattle's contributing to this data set and they just happen to give lidocaine, right? They're going to have great outcomes because they're bystander CPR and their systems of care that they've set up, right? So maybe there's just a couple high performers that administer lidocaine that are driving this whole signal. But it actually looks like those agencies that prefer lidocaine overall, even for the patients that don't get lidocaine or amiodarone, right, their patients do worse.
What we're finding here is that lidocaine does better despite that.
Correct. Yes.
Yes, it definitely seems like that should strengthen your confidence in the results.
Yes. Yeah.
Well, I'll tell you what, I think we have, I don't really want to say beat to death because that would be poor choice of words, but we have in-depthly covered your paper. Tanner, as always, thank you so much for joining us. I really appreciate it. Fascinating discussion. Congratulations on some great work here.
Thank you. Appreciate it.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.